We always say that oncology is forgotten child of the war, and it's a little bit forgotten child of our conference too. It was supposed to be actually the last session, but because Natalia Kovalchuk needs to get on a plane, we moved it down. But I hope we pay attention to this. It's very important. Cancer does not stop during the war. Patients with cancer fight two wars, with cancer and with Russia. And very important for us to discuss this. So our first speaker is Dr. DARYA KIZUB, breast medical oncologist from MD Anderson, and she leads our oncology program at Global Medical Knowledge Alliance.
Hi, thank you very much for inviting me to speak today, and I'm going to speak about the oncology needs assessment that we did for the World Health Organization in Ukraine. I've been asked to go through this quickly, so I'm just going to give a high-level overview. So just a disclaimer, this is a kind of a draft presentation and preliminary recommendations that the World Health Organization is still looking through and approving. This is the outline. This is information about the WHO collaboration in Ukraine. There has been a memorandum of understanding since 2022 with the WHO country office, helping the Ministry of Health, including related to cancer care. These are our assessment objectives. We looked at the gaps in the current cancer care infrastructure, including medications, technologies, the National Cancer Control Plan, and mapped current and future investment priorities to strengthen cancer care in Ukraine. We conducted a literature review, looked at patient and facility data from the National Healthcare Service of Ukraine, did oncology center visits, stakeholder interviews, and analyzed and integrated the data. These are the centers we visited. You can see Kyiv, Cherkasy, Dnipro, Mykolaiv, Zhytomyr, Ivano-Frankivsk, so cancer centers across Ukraine. And we conducted interviews with doctors and physicians at these centers. We talked to everybody who is a key stakeholder in Ukraine, from the Ministry of Health to key stakeholders in patient advocacy, palliative care, hematology, medical physics. We also talked to the key international stakeholders, the World Bank, IEA, IARC, ASCO, GMK, Help Ukraine Group, the Union for International Cancer Control. This is some data from the cancer registry. We can see that cancer incidence mortality decreased first with COVID-19 and then after Russia's full-scale invasion. The stage 3 and 4 presentation, interestingly, did not change either with COVID-19 or the invasion, and that has to do with, we think the coding of the stages in the National Cancer Registry needs to be improved. You can see cancer prevalence for 2023, almost 1 million people living with cancer, and the most common cancers being breast, colon, lung, and so on. This is information about cancer incidence from the National Healthcare Service of Ukraine billing data. So you can see these are just numbers because there's no stage data, so there's not a meaningful denominator. And currently, accurate data is dependent on coding by physicians. So for example, data for receipt of radiation therapy is not accurate, but we do have this data to refer to and track. Looking at the NHSU data to track changes related to cancer care during the war, we can see that from 2021 to 2024, chemotherapy treatment increased despite a decrease in patients and number of facilities that provide treatment. And we think it's because cancer has been diagnosed at later stages to where people are needing more chemotherapy courses. And the number of healthcare facilities has also decreased. Cancer surgery increased in the north and west despite a decrease in the number of healthcare facilities. Again, we think that's in part due to how the physicians are coding the surgeries. For radiation, overall radiation treatment capacity decreased. It decreased in the east, south, and west, and it increased in the north and center. And radiotherapy episodes per patient facility and number of patients per the facility has been stable. But again, it decreased in the south, east, and west. We think in the west because patients traveled abroad, and increased in the center and north because they accepted the extra patients. There's a lack of objective data about outcomes for treatment of Ukrainian cancer patients abroad, but for example, there were over 7,000 new cancer diagnoses per year just in Poland among elderly refugees, so it's a big issue for Europe because they're providing essentially free cancer treatment under the temporary protection afforded by the European Commission. We know that by August of 2025, of 1,505 patients who applied for medical evacuation, 853 were evacuated to 16 EU states and Norway, and 22 are waiting for evacuation. And there have been effective programs for both adults and children in collaboration with the European Union and other countries. These are some metrics about cancer care financing in Ukraine. Almost all cancer care is covered through universal health insurance, but patients do report paying over 50% for both cancer diagnosis and treatment. In 2024, the Ministry of Health spent about 200 million euros on cancer treatment, and about 79 million of that was specifically for cancer drugs and their administration, which is similar to the proportion of the Ministry of Health budgets in European countries. But because of lower GDP per capita, there's a much lower proportion of money that's available for cancer drugs, so insufficient access to kind of novel drugs and immunotherapy as expected. In terms of cancer care gaps before the war, so Ukraine did have and does have a robust system of cancer care, but there are some gaps. In terms of oncology training and education, the medical curricula across cancer subspecialties and also in palliative care are not up to European standards in terms of content and length, although that's changing. And the Ministry of Health is working on that. There's an insufficient number of trained personnel to support the safe and effective use of additional linear accelerators. Additional radiation oncologists are needed, radiation therapy technicians, medical physicists. There are only 3 PET CTs and 2 cyclotrons, so insufficient for cancer staging and treatment, although again, the Ministry of Health is working on that. For cancer screening, the screening is opportunistic and there's no department at the Ministry of Health in charge of cancer screening. There's issues with access to cancer screening modalities for cervical, breast, colorectal cancer screening, although again, this is being addressed. In terms of the National Cancer Registry, there's no data related to quality assurance for cancer screening. The cancer stage is outdated. There's no 5-year survival data, no childhood cancer data. The current mortality data is incomplete. The NHSU billing data does not include cancer stage, new or prevalent cancer, and it's not reliable for diagnosis or treatment receipt. For cancer diagnosis, there's discordance between public and private laboratory results, and not all cancer centers have MRIs or bone scans. And then molecular pathology and genetic testing is only available in the private sector out of pocket. In terms of access and cost, again, limited access to immunotherapy and novel drugs, to chemotherapy ports, surgical laparoscopy equipment, Linacs. And the actual cost of cancer care is not known outside of what is reimbursed by the National Healthcare Service of Ukraine. And then finally, in terms of quality assurance, the Ministry of Health actually does not have oversight over cancer centers outside of the NCI and the Children's Hospital Ahmediyat, making quality assurance difficult. Post-treatment surveillance is not standardized and neither is multidisciplinary consensus, and treatment is not always concordant with international guidelines. There are national guidelines that are being updated with more frequency right now, but they include both drugs that are not reimbursed by the NHSU and those not available or registered in Ukraine, so it's difficult to access guideline concordance. But again, in the National Cancer Control Plan that was adopted in 2024, despite the war, it does include the most important priorities to improve cancer outcomes that I have described, so the gaps are known and there's a plan to address them. Unfortunately, currently allocated personnel and technical expertise and funding are not sufficient for implementation. And there's a mismatch between capital investment and workforce development. So more emphasis on equipment compared to personnel training needing to run the equipment safely and effectively. In terms of changes in cancer care after Russia's full-scale invasion, right now, as everybody knows, the healthcare budget is mainly supported through grants and donations from international partners. The Ministry of Health priorities are focused on wartime needs, not the National Cancer Registry, cancer screening, implementation of the National Cancer Control Plan, or quality assurance, although some steps are being made in that direction. There's no funding for the National Cancer Registry data collection after 2023, so it'll be difficult to track cancer epidemiology and outcomes. There are fewer healthcare facilities providing chemotherapy, cancer surgery, although now there are opportunities for medical evacuation and treatment abroad. And also there's patient medical personnel migration from East, South to Central and West Ukraine, and drug and personnel shortages that still persist. Over hundreds of clinical trials have been halted in Ukraine for cancer, which is how patients used to get access to novel cancer drugs. But on the other hand, some trials have reopened and some drugs have been more available through humanitarian assistance and international collaborations. There have been challenges with Linux installation because of the war, and replacement of old cobalt sources. And again, lower cancer incidence and mortality, we think, because of lower case detection and later stage of diagnosis. On the other hand, we have seen a lot of resilience where cancer care returned to pre-war levels in August of 2022, 6 months after starting the war, which is actually very incredible, with patients and physicians reporting short waiting times for many treatments. As I mentioned, the National Cancer Control Plan has been adopted, including new cancer screening legislation, provisions for HPV vaccination and testing, multidisciplinary consensus prior to treatment mandate, and criteria for childhood centers of excellence, as well as new cancer drugs that have been funded. So really incredible considering the wartime challenges. These are the current and future investment priorities to strengthen cancer in Ukraine. And I put in the different international partners who can help with each priority. So these include workforce development, kind of bringing education up to international standards and support for attendance of oncology conferences, access to evidence-based resources for cancer diagnosis and treatment. Also, priorities in the National Cancer Registry, basically support for integration of the National Cancer Registry with the NHSU data and technical assistance and funding for personnel time for this integration. For cancer screening and early detection, IARC has offered to help with kind of program evaluation and implementation and design. And also one of the recommendations is support for increased availability of screening and diagnostic tests related to cancer screening. For cancer diagnosis, we need quality improvement programs and capacity building initiatives for pathology diagnosis, and advocacy for access to genetic testing and molecular pathology, as well as personnel training to support it. Also support for initiatives to raise public awareness about cancer symptoms and training for primary care physicians in this area. For cancer care access and cost, again, we need support for healthcare technology assessment and cost effectiveness as a basis for packages of medical guarantees that are reimbursed through the National Healthcare Service of Ukraine, and advocacy for national treatment guidelines to include resource stratification. So have a distinction if drugs are covered by the NHSU if they're available in Ukraine, so that guideline concordance can be evaluated, because this is something the international partners are also asking for. And then to advocate among industry partners to reopen cancer clinical trials, which has been happening, but we just need more of it. From the quality assurance standpoint, we need support and technical assistance for quality improvement initiatives, including related to multidisciplinary consensus, palliative care, guideline concordant care, and patient safety, and support for creation of criteria for reference centers of excellence for adult patients, including tied to quality indicators, the same way that right now exists for pediatric oncology. And the WHO office is working on supporting the Ministry of Health through that. And then we also need support for some oversight of quality guideline concordant care provision at regional cancer centers, whether the MOH or the NHSU. And finally, support for adult and pediatric advocacy organizations that do extremely effective work related to quality improvement and policy change efforts. So, kind of in conclusion, most needs to strengthen cancer care in Ukraine are for personnel training, including to ensure safe and effective use of installed LINACs, MRIs, and later PET-CTs that are planned for purchase, and processes to ensure high-quality data-driven, guideline concordant care and optimized and transparent use of limited resources. So, for example, ensuring consistent supply of funded drugs, as opposed to obtaining novel, expensive drugs. And then for capital equipment and investment, it really needs to be tied to assessment and assurance of facility readiness, including through workforce development to ensure safe and effective implementation and utilization. And again, the Ministry of Health and HSU do not currently have sufficient personnel or technical expertise or funding to implement a lot of the recommendations given here today without pulling these from other priority areas. Although one strategy could be to pull funding from planned equipment and capital investment purchases and redirect it to other areas like the National Cancer Registry or cancer early detection or quality improvement. Because, for example, you can use the money from one PET-CT and fund the National Cancer Registry data collection. So international collaborations and support will be key to help Ukraine and the Ministry of Health achieve the goal of bringing cancer care up to European standards. And again, these are some of the international partners who have helped. So with that, I would like to thank everybody, and including the WHO country office and the European Commission for funding the study, as well as everybody at GMK for helping with the data collection, everybody who helped participate in the interviews, and the patients and patient advocates. Thank you very much.